First and foremost, I just want to thank you all for being here and taking the time and the investment, because it demonstrates your investment in your overall health. And I think that deserves to be recognized. So good for you all for coming, and we are so appreciative that you are here. My name is Rose Ryder, and I'm the Manager of Business Development at MemorialCare Long Beach Medical Center. And we are lucky to have two incredible specialists with us this evening talking about neck and back disorders. First is Dr. Amandeep Bhalla, Medical Director of the Spine Center at Long Beach Medical Center, and then Dr. Hanna, who is the Medical Director of the Back and Neck Health Center. Both of them each bring unique perspectives to neck and back pain and disorders, but those perspectives, I think, share the common goal, and that's really that everyone here can be able to move freely, be agile, pain-free, and to really manage the discomfort and the pain so it doesn't hinder our living. They're also going to be sharing from each of their perspectives the latest innovation, based on latest research, their own experience and expertise, and then also real-life patient examples. So I have no doubt that whether you are here for yourself or for a loved one, that you're going to be in good hands and you're going to walk away with some great information that you can take from this and implement as needed. So with that, please join me in welcoming I apologize. We're going to go through the presentation. Afterwards, we'll do Q&A. And for those who are joining us virtually, please type in your questions into the chat area because they will be read and answered by our specialists here. So with that, please join me in welcoming Dr. Bhalla and Dr. Hanna.
Hello, good evening, everybody. I am Dr. Hanna, as you could see here. So welcome. It is a pleasure to see you all. I am the medical director at Long Beach Healthcare Center for the neck and back. So it is a pleasure to be here. Thank you, everybody, for putting on this great event. And thank you for taking the time to come hear us out. Hopefully we could provide you some good insight and answer any questions you may have. Okay, so who here has back pain? Okay, so statistically speaking, about 80% of people will likely have back pain throughout their life, estimated even to be more. Whether your back pain is persistent, acute, meaning sudden and stays short interval, or long-term, back pain can occur in multiple different aspects, okay? So let's get started here. So the first picture here I want to show you guys the first thing I want to tell you guys is, there's different types of back pain we should all be made aware about, right? There's back pain that could shoot down the legs versus back pain that just stays localized in the back. That's something as patients we should all be educated on, okay? When I say back pain, same thing goes for the neck. You could have neck pain shooting into the arms and neck pain staying localized to the lower back. Say it again? No, unfortunately, this is the best I can get right now. I apologize. But I'll do my best to explain it to you. So this picture here on the left, okay, is for what we call axial back pain or axial neck pain, okay? Axial means it stays localized to that region. Now, these pictures here show that when someone has back pain or neck pain, it could feel like it's being caused in other parts of the body. For example, if I have neck pain caused by the arthritic joints in my neck, it could feel like I also might have a little bit of shoulder pain. I also might have a little bit of a headache. I might have a little bit of side neck pain, or what we call trapezius pain. That's this picture on the left. We call that referred pain. If we go to the next picture over to the right there, where the green picture is, you could have also arthritic joints in the lower back called facet pain, and it could feel like it's causing pain in just your lower back. It can feel like it's in the buttocks or even down the back of the legs, okay? So these are different types of pain with different types of pain patterns. So why back pain happens? As mentioned earlier, 80% of adults experience back pain at some point, okay? Common causes of back pain. Arthritis can be a cause of back pain. discs that wear and tear. Discs are those cushions between your bones in the neck and in the lower back. Spinal stenosis. Spinal stenosis is narrowing of the nerves in the center of your spine. So as your nerves come from the brain and go down your spinal cord, and then they exit the spinal cord and go out to the rest of the body, any pinching along that route can cause some sort of pain and some sort of neurological dysfunction. And what I mean by neurological dysfunction is things like numbness, tingling, weakness, things of that nature. Facet joint inflammation. Facet joint inflammation is a fancy term for arthritis as well of the joints in your lower back. And I'm going to leave the microphone here for a second to just point at it. But so, do we have a cordless mic by any chance? I like to walk around and jump around, so I'd appreciate it. So these joints, you see where this green laser pointer I'm pointing at right now, meeting with this bone right here, those are called the facet joints where they meet. After the age of 40, it's actually very, very common. Thank you. As we age, we are in one of the heaviest working environments in the world. America loves to work us, right? So, postural changes are very common, and they're biomechanical changes our bodies take when we sit down for long periods to work. When we have, when we go shopping, we might be, walking around incorrect ways. Our shoulders are bent forward, they're not bent back. And over time, we decompensate and we don't make the appropriate changes to intervene to allow us to have the appropriate posture, okay? Pain can be localized, as I mentioned, which we call axial in medicine, meaning localized to one region, or radiating, which we call radicular, or the common term people use is sciatica, meaning it shoots down the leg, okay? Anybody have any questions so far? I know we're saving questions to the end, but just in case. Okay. So here's a nice little chart I made. Okay, so axial pain, again, localized to the back or just the neck. People tend to describe it as aching, stiffness in the lower back or neck. Common causes are arthritis or muscle strains. And then you have radicular pain. Remember, shooting pain into the legs. Shooting pain into the legs, we tend to think, okay, it's a pinched nerve coming out of the lower back. Usually due to a herniated disc. And then neuropathic pain. Neuropathic pain means nerve-like pain. It's just a description of pain, okay? So it could feel like numbness, tingling, burning. It's usually due to nerve injury or some sort of insult to the nerves. So the first step with back pain is usually what? It's conservative care. So we always start with non-invasive options. So when I started at this center, I took on the role to make sure that our patients, when they are referred to physical therapy, they're seeing physical therapists one-on-one. Meaning, you're not going to a physical therapist and they're handing you off to an assistant or an aide and walking away and telling you, go ahead and kick your legs out on a chair and we'll be back in 20 minutes, right? I want them to actively be involved with you. I want them to actively activate your muscles and make sure your core is strong and make sure they're also giving you home exercise programs and educating you on proper ergonomics. Next thing is they'll go through gentle strengthening and flexibility programs, focus on core stability, and a big thing that I preach is avoid long-term bed rest. So back in the day when people used to have back pain, it used to be just lay in bed. You'll be fine in 6 weeks, right? But that's not really what's recommended now. We actually recommend the opposite. Let's get you moving, let's get you strong, let's get you functional, okay? So as I mentioned, one-on-one physical therapy ensures safe, guided movements tailored to your needs and helps restore function and reduce pain. When pain persists, so let's say you did do physical therapy, okay? And physical therapy, you've tried it and you're like, Dr. Hanna, I've done physical therapy. It continues to be bothersome to me, this pain. It's just my neck, my back. It's constantly going. Okay, what do we do next? So that's where I step in. As an interventionalist in interventional pain management, I begin to talk to you about possible interventions and procedures. Okay, so procedures can go anywhere from diagnostic blocks to help identify the source of your pain, such as injecting lidocaine to those arthritic joints I discussed with you earlier, and those nerves that go to those arthritic joints. And then once we can confirm that that is one of the causes of your pain, we can go ahead and proceed you to something called an ablation. An ablation is using these fancy needles, as you can see here, what we call ablation needles. Okay, and then we guide it to the nerve that takes the signal of pain from those joints in your spine, and we actually burn them. Okay, it's called a radiofrequency ablation. So that way, it stops the signal of pain from being relayed to that joint to the brain. okay? So some of these procedures obviously helps us diagnose and helps us treat. Another type of procedure that we do is something called an epidural. Not the same type of epidural one is given during pregnancy or delivery. It's a different type of epidural. Epidurals are given in the same space. Epidural is a space in the spine. That's all it means. But we're injecting medication into that space in the spine. Usually it's a steroid medication, and it tells that pinched nerve to calm down, okay? So when you calm down a pinched nerve, it should help with that radiating pain in the leg. Does it always help? Absolutely not. But it is an intervention that we could attempt. So common interventional procedures, as I just mentioned. Go ahead, question? Great question. So I'll make sure to answer that at the end one more time. But the question that was asked is, for the burning of the nerve, how long does that last? So the research points actually anywhere from 6 to 18 months if it is successful. Prior to becoming a candidate to get your nerve burned in that area, specifically the medial branch nerve in the facets, you have to undergo 2 successful diagnostic tests, meaning we just inject lidocaine around those nerves to confirm that those joints are what is causing your pain. Does that make sense? Okay. So we talked about ablations, we talked about blocks, we talked about epidurals, and there's sacroiliac joint injections. Sacroiliac joint injections are commonly, or sacroiliac joint pain is commonly missed. There's research that points that it could be accountable for 20 to 35% of back pain. It's the lowest part of your back where the sacrum meets your hip joint. So sacrum, the first word, which is the lowest part of your spine, kind of where your tailbone is, and the iliac, which is the iliac crest, which is that hip bone, okay, that comes around. It's where they meet in the back, okay? So there's a lot of tests I'll do during clinic to identify the source of your pain. So advanced options for back pain. Let's say you've tried everything. You're like, Dr. Hanna, I've tried the physical therapy. I've tried the injections. I have tried surgery. What other options do we have right now? The last resort we have is something called the spinal cord stimulator. And we've used spinal cord stimulators in patients who suffer from diabetic peripheral neuropathy, meaning patients with severe neuropathy in their feet. They're in a lot of pain. They've tried everything. Nothing can work. Spinal cord stimulator is indicated. And for patients who've undergone surgery and are just not getting relief with pain. The theory behind spinal cord stimulation, is we are distracting your nerves from feeling pain. Okay, that's what we're doing. We are distracting your ability to feel pain. It's not fixing the underlying condition, but it is allowing you to be distracted from feeling pain, giving you quality of life back. What is different about this procedure is you get to try it first before you get it implanted, okay? Meaning you have a spinal cord stimulator trial where we put these 2 very thin-like, hair-like structures into your epidural space. We attach it to a battery, and we stimulate that battery. And when we stimulate that battery, if you do get relief, it tells us, and what I mean by relief is good relief, meaning you're like, Dr. Hanna, this is life-changing. I finally can function again. The pain is not there. But if you get that significant relief, it tells us that you can go ahead and proceed to an implantation, okay? Obviously, with all of these procedures, they come with the risks, which we'll discuss at the end. So, again, why see an interventional pain specialist, right? And I see this happen all the time. Patients, they go to their primary care doctor, they're like, I'm in pain, right? And the primary care doctor's like, oh, well, take some Advil or take some medication, go to physical therapy. I always preach it's always good to see an interventional pain specialist, not because I'm trying to advertise myself, but more so is you want to know your options as patients. You want to know what's out there. You want to know how else doctors can provide you with relief, but more importantly is what is the diagnosis? Pain is a symptom, right? You could have pain anywhere in your body, but what is causing that pain? My job is to step in and help you figure out what is causing that pain. And the goal, as you know, is restore function, reduce pain, and improve quality of life. Key takeaways: most back pain improves with proper care and guidance, okay? Start with one-on-one physical therapy and lifestyle modifications. If pain continues, safe and effective procedures can help, okay? Spinal cord stimulation is available for the right candidates. And I would always talk to an interventional pain management physician before considering surgery. And if surgery is indicated, of course, you will speak with the surgeon and be referred to a surgeon, such as Dr. Bhalla, okay, who will talk to you shortly. But again, there's indications for each thing, but understanding the overall picture of where us physicians, or how us physicians can help you is key, okay? So speaking of surgery, I will be introducing next the great Dr. Bhalla, who is a fantastic spine surgeon and my patients have done great with. So here's Dr. Bhalla.
Thank you, Dr. Hanna. Appreciate it.
Of course.
Great. Good evening, everybody. Good evening. Thank you. I see some familiar faces, and so good to have all of you guys join us, particularly on this rainy day. And I know there's at least a couple hundred people joining virtually online, so thank you all for joining as well. Dr. Hanna, that was a great kind of introduction. So just to step back for a moment, Dr. Hanna's if you didn't catch it, he's a pain management doctor interventionalist. So it's a type of physician that specializes in performing interventional or diagnostic type procedures to help establish what a pain generator is and potentially treat it. One further step in that continuum of care is where I am as a surgeon to kind of surgically help potentially spinal conditions or also guide non-operative management. So we really work in tandem. We send patients back and forth all the time to help get the most comprehensive care for our patients. So we'll go ahead and get started. There may be a couple points that you've heard already, but we'll start with the kind of the basics, as I think that's helpful. It's very helpful to take calcium and vitamin D supplementation for the maintenance of your bone mineralization, which is basically the ability of your bone to withstand stress. And so after the age of 35, all our bones are resorbing over time. So they're gradually getting weaker. And then postmenopausal, particularly in women, that bone resorption increases a lot. And so it's good to get at least 1,000 to 1,200 milligrams of calcium a day, or at least 800 to 1,000 international units of vitamin D3 as well. And there's no need to break the bank for this, really. Even just like the multivitamin at Costco, just double check the label. They have these in them, but I think it's worth taking to help keep your bone strength and mineralization optimized. So this picture here on the right kind of illustrates bone that's a little bit more, it kind of looks like a little bit more Swiss cheesy, where there's more kind of holes in it. This has less mineralization, whereas this is a more fortified, mineralized bone on the left. And one of the possible complications of having poor bone mineralization is to develop something called fragility fractures. Basically, fractures that are a function of having weak bone. So, for example, a hip fracture or a wrist fracture. In the spine, we see something called a spinal vertebral compression fracture. So this is a little illustration of that. It's good to consult with your primary care doctor, particularly over the age of 65. Medicare actually allows for a DEXA scan, which is a bone mineralization density scan, to be taken once every 2 years. So that's covered by Medicare. And that's something that you guys should seek out and make sure we're on top of, so that if we are, for example, losing bone mineral density, we can always catch it before and intervene potentially with medications or increased supplementation. So I think that's an important preventative health measure for all of us. And another good way to maintain your bone mass is to do weight-bearing type exercise. So walking is excellent. Also, lifting weights, 2 to 3 times a week, some type of resistance exercise. And it's not about lifting heavy. It's really just about being consistent, letting your bones see some stress so that they develop in response to that stress. In people with a lot of arthritic conditions or achy parts of their bodies, doing pool-based exercises can be helpful too. It takes the gravity, away from it, and so your joints see a little less stress, a little less pain to do those activities. And as Dr. Hanna was alluding to earlier, maintaining a strong core is very helpful because that kind of dynamically stabilizes your spinal column and helps to take some of the stress off of the discs as well. Here's a little rendering, kind of a picture, a sideways view of the low back. And, the vertebrae are these blocks of bones, and there's this little squishy cushion that serves as a shock absorber, which is a disc. Now, over time, just naturally for all of us, these discs, they tend to wear and tear, lose a little height, lose a little bit of that shock-absorbing ability, and they tend to dry out a little bit as well. And that's kind of illustrated here. Sometimes you can have bulging of the disc, which is illustrated on this next level here, or even a herniated disc, which is kind of when disc material is no longer contained within the disc space, but has moved out to where the nerves are, and that can cause significant nerve pain. Also, in arthritic spines, you can have bone spurs or loss of disc space, which can also result in pinching of the nerves. So this picture summarizes like multiple types of conditions that affect our spine that can cause pain or weakness or numbness or tingling. And it's totally normal, for some of these processes to occur. It just becomes an issue when some of these degenerative changes are pushing on nerves and causing symptoms. So, for example, having a pinched nerve in your neck that causes shooting pain, numbness, tingling down the arm or hand, or having a lot of narrowing in the spinal canal in your neck that makes you unstable and have difficulty with walking. Similarly, in the low back, you hear the term sciatica. Sciatica just refers to pinching of the nerves that contribute to the sciatic nerve, which can cause pain kind of going down the leg. A lot of people, when they have these degenerative changes, find it difficult to stand and walk for prolonged periods of times because that pressure on the nerve is causing something called claudication, where you have pain developed from the compression. I like this picture because it summarizes in a different way what I'm talking about with the degeneration. This is a vertebrae, and this is the canal. You talk about the spinal canal, and we're looking from top down through the spinal canal. So it's as though we're looking down this way through the spinal canal. And so this is a cross-sectional view. The spinal canal has three main stabilizers. One is the disc in the front, and then second and third are the two joints on both sides. So what happens with arthritic wear and tear is this disc can start bulging out towards the canal, and these joints can overgrow, crowding space in the canal, and you see that really nicely depicted here. So what was a normal canal with plenty of space for the nerves to run through it is now narrowed over here. And that is classically what you hear about, that explains what stenosis is, which is basically not enough space available for the nerves to pass through anymore. And so here's an MRI where you see all the nerves here kind of passing through, and these are the same nerves that run down through your low back to your legs. They're passing through until they get to this point here where they're significantly pinched. And that can cause symptoms of stenosis, which is that standing and walking intolerance, or shooting pain down the legs, or weakness potentially in the legs as well. we talked about, the way we like to treat it. So at MemorialCare, Long Beach Medical Center, and the Back and Neck Center, we're pretty disciplined in wanting to try conservative measures first, particularly when appropriate. So that is strengthening, low back core exercises, anti-inflammatory medications as well. If you are amenable to it, another option is also considering an interventional injection, so like a referral to a specialist such as Dr. Hanna. And in some cases, the symptoms persist in spite of these conservative measures, in which case surgery can be extremely effective when the right surgery is done for the right problem, okay? And so that's the key, right? So, the indication for the surgery is the greatest predictor for the success of the surgery. So, I always hear patients come in, they say, I heard from so-and-so, never get back surgery done. And, I agree with that, unless you have an excellent reason to do it, and if it's changing the quality of your life and you failed conservative measures and the treatment that's being offered to you is evidence-based, then those are patients I know we can help. And so it's very important about going through that right process, being informed regarding what the condition is, and making sure that you're getting the right surgery for the problem that you have. So in this particular case, here's again that cross-sectional view. This is an MRI showing those nerves in the low back being really compressed. This patient underwent a laminectomy where we shaved back some of that arthritic compression, and you can see now that there's a lot more space available there for those nerves to pass through. So that's kind of this is before surgery and after surgery in this example of a patient undergoing a lumbar laminectomy. And we talked about this already, when people might consider that they need spine surgery is, when they have significant symptoms that have failed conservative measures, when the imaging evidence, so x-rays, MRI, CT scan, point clearly to a problem that we know we can help with surgery. And that's done collaboratively with, multiple visits with your physician, a lot of education. Sometimes if we're trying to figure out exactly what the pain generator is, we have a low threshold to enlist the expertise of someone like Dr. Hanna to help diagnostically determine. I'll give you a quick example because a lot of patients, sometimes they'll come in, they'll say, my hip is killing me. And then we say, okay, can you show me where your pain is? And then they'll point right here. And so oftentimes hip, so the hip joint, usually you'll actually have symptoms more in the groin area. And a lot of times symptoms in this gluteal area, what they're referring to as the hip, actually can be coming from the low back. And so Dr. Hanna, in a situation like that, might do a steroid injection in the low back, and if that alleviates the pain in this area, then the patient then understands that indeed the symptoms are coming from the low back. So that's an example of how we use that kind of diagnostically and potentially therapeutically. Sometimes conversely, we'll inject the hip joint to see if that gets rid of the pain. If that gets rid of the pain, then we know it's probably more hip arthritic in nature versus coming from the low back. So that's kind of how we work to figure out how we can best serve the patient. Yes, ma'am. Sure, absolutely. So basically, all of our nervous tissue is kind of, everything's coming down from the brain and it's going down through the spinal canal. And so you have your spinal cord, which I refer to as like the main computer, sends all the signals, your muscle activity, sensory fibers through the neck, and then those nerves exit and go to the arms and hands. And the termination of the spinal cord is the nerve roots in the low back, and then those nerves innervate the legs and feet. So it's really a passageway, the spinal canal. And so if the passageway gets obstructed by arthritic changes or disc herniations or bone spurs, that's when, potentially people have symptoms. A lot of people have arthritic degenerative changes, but it doesn't block the passageway, in which case that's totally fine. If you were to get an MRI on a room full of people, adults, with no back pain, no neck pain, you'd see degenerative changes, disc bulges, bone spurs up and down the spinal column. So most people with degenerative changes have no symptoms, but it's when it starts to block the passageway and push on the nerves, that's when people can develop symptoms. Yep. Yeah. Yes, ma'am. Mm-hmm. Mm-hmm. Yeah, it's hard to get too specific on an individual level, honestly, without having your images and studies available. Oh, thank you, Rose. Yeah. So the nice lady had just asking about symptoms she has in her neck, going down the shoulder, down the right arm. She's trying to figure out what could be the cause of that. And my response to that is really, I think we would want to have the benefit of the imaging studies, physical examination. So you really would want to consult with a physician just to figure out kind of what's causing that. But in short, you're correct that symptoms going down the arm could potentially be coming from an issue in the neck. Yeah. And just before we open it up to questions, I did want to bring home one final point, which is I feel very blessed to be a part of the MemorialCare Long Beach Medical Center community. And one of the reasons is, there's many reasons, but one of the reasons is there is no medical center that I know of in the area that has invested more in advanced technology than this medical center, specifically for the spine. It's really mind-boggling. I mean, we have the latest intraoperative imaging platforms. We have the latest robotic platforms. It rivals and surpasses many of our university partners that are kind of in the area. So it's really exceptional what they've done at the hospital to promote that and to make sure our community basically has the best stuff around for the spine. So that's one of the advantages that we have at the hospital, in addition to kind of very skilled nursing staff, physical therapy, comprehensive neck and back center. So we feel like patients are kind of well served in our area. But Rosa, should we open it up for questions or?
Yes.
Okay.
So first and foremost, thank you, Dr. Bhalla, and thank you, Dr. Hanna. How many of us are walking away with some new information this evening? Yeah, good stuff, and we really appreciate that. So I'm going to go and take some questions. What I'll do is I'll go to you and ask that you speak in the microphone, and the rationale is so that the friends who are on virtually can hear the question as well. And for those who are online, if you want to go ahead and submit your questions in through the chat, we will then read them as well. And I see a woman raising her hand over here.
I have some questions, please. Lower back pain and peripheral neuropathy in the hands and feet, are they connected? And if so, how? And then what treatment options are there?
So that's a great question. So let me just reiterate what you asked so we're on the same page. So you're asking if lower back pain has any connection to peripheral neuropathy. So lower back pain can occur independently or separately from peripheral neuropathy, meaning they're two separate diagnoses, okay? Now peripheral neuropathy, and I'm going to try to be as clear as possible, peripheral neuropathy means, you can get pain in your hands and your feet from nerve pain. But that nerve pain itself, right, can be caused by a pinched nerve in the back. Usually, as Dr. Bhalla said, it kind of radiates down the leg. But with neuropathy pain, or what you're describing as just separate foot pain and back pain, those are usually two separate diagnoses in most cases. Does that answer your question? Almost. Go ahead and specify it, because I'd like for you to
Okay.
get your
'Cause
answer.
I have been dealing with it. I have pain that goes from the waist down to my toes.
Right.
And I'm trying to figure out which is which and how's the best way to handle it.
So that's a great point. So you have pain going from your back down to your toes, similar. So it's radiating down the leg, from my understanding, right? Obviously, this is not a clinical visit, but when someone has pain radiating down the leg, the question is, how do we diagnose that appropriately? So getting an MRI first to see, is there a pinched nerve that is causing this type of pain? There's also something called an EMG nerve conduction study, which we can perform, where we actually poke you and shock you in your muscles and nerves to see the health of the nerve and to see if there's any type of nerve compromise, such as a pinched nerve, or is it a true neuropathy, such as a peripheral neuropathy. So again, to answer your question is, they are usually separate diagnoses, but they could also be one diagnosis. But that's usually the clinician's job, is to delineate or differentiate between both. Does that answer it now? Kind of. Oh, you're a tough one.
Yes, doctor. I have a question. Right now, I have a pain in the left neck. Okay, no tickling in my hand or my leg. No pain. Just no pain anywhere except the neck. And also, I have sometimes I feel on my left side of the head, like somebody pull the cold water or blow the cold air, like that in my inside my head. So I don't know what is that, and I have a MRI, and I went to see my doctor, and they say I need the fusion operation, because then my fusion surgery, because is one of my they need to carving the bone structure put inside my neck, so we'll be eliminate that. Would you help me, please?
So, I think it's always helpful to get other opinions, get a second opinion. I encourage that. I think you should be wary of a doctor that doesn't want you to get a second opinion. I think so. I think it's helpful. The more you learn, the more you understand about it, the better decision you're going to be able to make. I can't really, of course, speak to your specific case without a bunch of other information, but get a second opinion. Make sure you feel comfortable about the information that you have and your understanding, and then that's going to help you make a good decision for yourself.
Thank you.
Yeah.
We have a line, one of our questions that came in was, for a patient with worsening sciatica and back pain who has not responded to an epidural or multiple medications and whose surgery consult was denied by Kaiser, what are the recommended next steps for pain management, and how can she safely seek care or specialist consultation outside of Kaiser?
It's a great question. We actually see a number of Kaiser patients that want to see, get outside opinions, really. And so they can see any of the specialists, for example, on panel at MemorialCare Long Beach Medical Center. But I, of course, they only accept Kaiser insurance within network, but you can, there's always a direct pay option. And so my message to that, the person who asked the question is, you definitely have options. Make sure you're satisfied that you're being heard, that you have had the opportunity to get the opinions that you want to get, and give us a call. We'd be happy to help you.
Okay, thank you. I have another question from online. Someone wrote in that they have a floating vertebrae in their neck, and it makes a very bad snapping sound in their neck. What could the patient do?
Sure.
Or what causes that?
Yeah, we'd have to take a look at their imaging,
Yeah.
honestly, to better understand it. Yeah.
What sometimes causes snapping or what some people call cracking? Like
Yep.
in-
So, so cracking obviously is a lot of people when I see them in clinic, they're like, "Doc, my neck cracks." Like, listen, hear this, And I actually physically don't hear it, but I believe them, right? So it's like I'm not, putting my ear up to their neck, like let me hear the cracking. But so it's like cracking your knuckles, right? Where your joints come together and you could hear them crack. Similar to the joints I discussed earlier and Dr. Bhalla discussed earlier, called our facet joints. Okay, those facet joints are all throughout our spine, throughout our neck, our middle back, our low back. So sometimes actually when we move our neck in different directions, such as looking up, left, right, and so forth, some people hear that cracking. And because it's inside of your body internally, it's actually amplified for you. So that could be a cause of cracking. But again, it's not a clinical visit. I have to say this every time, and I have to see the patient in person, and I don't have the appropriate imagings, but that could be the cause of cracking.
Okay, thank you.
I just wanted to ask, so what would a typical physical therapy session consist of for patients with neck or back pain?
So I'm not a physical therapist, but what it should consist of, okay, is going to be range of motion and strengthening exercises and progressing you as tolerated, right? So their job is to their first day they see you is for an evaluation, a comprehensive evaluation, is how far can you rotate your neck to the left, how far can you rotate it to the right, and they're documenting all these types of things. What degree level can you look down, and degree level you could look up. And the goal is to hopefully improve that range of motion with time by giving you exercises to strengthen, for example, the neck, the cervical paraspinals, your trapezius muscles, giving you the appropriate range of motion and working on those types of things, okay? So, and at the end, they'll evaluate you again and to see if there's any differences by your final evaluation, your first evaluation in terms of range of motion, flexion and extension and so forth. And they'll give you home exercise programs as well.
Yes, I have a question over here.
Yes, hi. What do you recommend for pain management on scoliosis that the spine is at a 45 to 50 degree curve?
I'll speak for the pain part. Sure. Yeah, so that's a very, very large curve. The Cobb angle, I believe we call it, correct? So that's a very large curve. With curves like that, obviously, we begin to get concerned for underlying physiological alterations, right? So when your spine curves that much, your lungs can alter their positioning, your heart can alter its position, your arteries, your veins, your nerves, your kidneys, and all that can lead to physical changes and physical symptoms such as pain. Again, without identifying the exact, and looking at the images and seeing the causes, is figuring out, well, we understand you have scoliosis. What is causing the pain? Is it due to a nerve being pinched because the scoliosis is so severe? Is it due to, a certain part of your body not getting the appropriate blood flow? There's so many reasons, but identifying that reason. But usually with curves that big, I believe, and correct me if I'm wrong, Dr. Bhalla, surgery is usually recommended.
Yeah. It really depends. It's a really good question. I think the way I would approach that is, just generally speaking, broadly, when we have a significant scoliosis, unless we see, if there's not a lot of nerve impingement, we would try to generally treat that non-operatively if we can. So we would try physical therapy, weight loss, low back core exercises, anti-inflammatory medications, potentially different types of interventional pain injections as well, whether it's epidural injections, facet joint injections, things like that. Because not everybody with a significant scoliosis curve is a surgical candidate as well. Scoliosis surgery can be large and significant. Sometimes the bones can't support it. There's a lot of risks associated with surgery. So it's a balancing act in trying to figure out that, we have to be confident we're going to help the patient. And so we would kind of go through that process. So there's no one straight off answer that I can give you, but it really would be a broad workup.
Okay, thank you. We have a question online, how do you treat cranial cervical instability? And what is that for those who may not know?
You know, it's an interesting question because there's some. So cranial cervical instability means like it's between your skull and the top of your neck. Now, if it was truly unstable, we'd have some real problems, right? You know, but you know, there are some, you know, for example, and I have nothing against chiropractors, believe me, but there are sometimes you get, you know, diagnoses like that thrown out there, and I don't really know what to do with it, you know. So so I think that's somebody where I'd want to see it myself and understand that what they're calling craniocervical instability, you know, what do they mean when they're saying that? And that's just, you know, sometimes, you know, things get labeled, and it's really helpful to get a little bit more information to know what they're talking about. Yeah.
Another question is, do you perform prolotherapy? And for those of us who may not know what that is, what is it?
So prolotherapy, the theory behind prolotherapy is agitating a part of the body. So what I mean by that is we take something called dextrose, which is sugar, pretty much sugar water, expensive sugar water, but it's sugar water, and we inject it into an area of the body to cause an inflammatory effect. And that effect should, you know, the theory behind it is it should provide pain relief in the future. Do I do it currently? The answer is no, I do not do it currently. I do PRP currently, which is platelet-rich plasma, but that's a whole other topic and discussion.
That session will be in 6 months. We'll see you then. I see a question over here. Angela, do you have any?
Yep.
Hi, question is for Dr. Hanna. I have osteoarthritis and lower back pain. So I was wondering, what test would you start with to help the physical therapist make a plan for me?
Okay, so, and sorry, I missed the beginning part. Can you repeat that one more time?
I have lower back pain and osteoarthritis.
Okay, so, and osteoarthritis. Osteoarthritis of what part of the body? If you don't have to answer that question if you don't feel comfortable sharing your medical information.
Shoulders, knees.
Okay.
So I assume it's the back too, but
Okay.
I don't know.
Yeah, so I mean, that's a great point. So a lot of people who have, you know, osteoarthritis is just, it's a term, osteo means bone, arthritis is inflammation of the joint. So there could be knee osteoarthritis, shoulder osteoarthritis, hip osteoarthritis. We have to name the joint, okay? Now, you also have back pain, right, which is a symptom. So remember, what is the cause of that symptom? Is the pain in your back due to the arthritis? Is it due to a disc protrusion? Is it due to the canal narrowing? We have to figure out that diagnosis first, correct?
Yeah, before you would see
So,
a physical therapist.
Exactly. So what I would do, to answer your question, is what I would do first is I'd bring you in and diagnose you and try to figure out what's the cause of that back pain. But physical therapy, right, their job is to optimize your body biomechanically in order to set you up for success, right? Because if I come in and I treat your pain, but you're still wobbling, right, long term, that wobbling is going to take an effect and toll on your body, causing other pain, because it's a chain of events, right? It starts out with just my ankle hurts, let me change the way I walk. Now that I change the way I walk, well, my left knee hurts. Now that my left knee hurts, my back hurts, and then soon your ears are hurting at that point. So it just keeps going up the chain, right? So does that answer your question?
Well, I was just wondering, like, what kind of tests do you do so that
Okay.
you can see, like, in the lower back, what would
Great.
be happening?
Great. So to answer that specifically is the test I would do for arthritis of the lower back is called a medial branch block, meaning I would take lidocaine and I would inject the nerves. If I see it on MRI and I see that you tested positive on physical exam, but I would inject the nerves that go to those arthritic joints with lidocaine. And if you get sudden relief that lasts you 2 hours, that diagnostically tells me the cause of your pain is due to those facet joints. But if you tell me after, Dr. Hanna, I got zero relief with that needle you just put in my spine, that tells me it's likely not the cause of your pain.
What's the difference between that and an epidural?
Great question. So an epidural is, so remember, the arthritis of the facet joints are those joints in the spine that touch. An epidural is addressing a pinched nerve, okay? And with that pinched nerve, that causes either shooting pain or what Dr. Bhalla said earlier, neurogenic claudication, meaning your legs feel heavy when you're walking because your nerves are so suffocated, right? That freeway or that pathway is really clogged up, and epidural providing steroid to that region can help provide some relief, temporary relief, or even give us good diagnostic information to tell the spine surgeon, like, hey, this is what we think is going on, and they'll make the final determination.
Okay, we had a question over here.
Yes, I have fallen on my front steps, and now I have back pain, and it radiates all the way up to my neck. And the only thing that relieves me is the biofreeze. But how long can I use that? You know, I have difficulty with my balance, and also I'm using a cane to help me along.
Sure. You know, I think the best way, we would have to get, you know, kind of imaging studies and kind of get an understanding of what's going on. And with that information, we'd be able to guide you. But I'm glad at least you're getting some relief with the biofreeze, and that you're using some type of assistance, like a cane, just to keep you safe so you don't fall. I think those are good things. Yeah.
So just call your office.
Sure, you're welcome to.
We also had a question from online. What is your opinion about acupuncture or chiropractic sessions? This patient has a herniated disc at L4, L5, and end tears in the rotator cuff.
Yeah, I think that's a great question. And I think it really depends. So I think acupuncture has a role, right? I think chiropractic therapy, I think, has its own role as well. I generally am not a fan of like significant manipulations and those types of adjustments. I think that can be a little bit dangerous because nobody really knows what's happening there. It's not a really objective thing to do. For a herniated disc, though, specifically with nerve pain coming from a herniated disc, I don't think that acupuncture is not really going to be too helpful at alleviating it. I think it's generally better for muscular type pathology. But a lot of herniated discs fortunately get better on their own just with time. And so sometimes doing some of these activities allows for the passage of time while it distracts you, and things kind of get better on their own. But what I would say in summary is best to get it evaluated, get some imaging studies like an MRI, and then first establish a clear diagnosis, understanding of treatment options, and then you can kind of go down different pathways potentially.
Okay, thank you.
I have
Angela.
a question here.
Thank you. I have scoliosis in my back, and I had an MRI. I had an MRI about 3 years ago, and I did physical therapy back some time ago. I do exercises at home periodically, not like a person should, I know that. So now I've scheduled PT at Memorial, and I wonder, should I see the doctor first before I see Lisa there, and get another MRI, or just go ahead with Lisa and let her do the exercises?
Yeah, well, you're in great hands with Lisa in PT. She's really good. I think you're being hard on yourself. It's good that you're doing exercise on your own. It's great, even though we all feel like we could do it more often. I think physical therapy generally is a positive thing. So particularly if you can continue to strengthen your low back and core, it's reasonable. What I would say is if you develop weakness or significant pain in the legs or arms or hands, then I think that's probably the best time to get a new MRI. But I would feel, follow the advice of your therapist too when you see them, and keep up the hard work. Yeah.
We have a question online. Someone had a successful spinal replacement surgery and is asking if there's a potential for airly or disinclination between the original surgery and future procedures in the same part of the spinal column.
my understanding of the question is somebody's had a spine surgery done in a certain area, and they want to know if that means it would be harder to do a spine surgery in the same area, or if they could have one.
That is my sense of the question as well.
Well, they said it was successful, which was great. It sounds like having, hopefully they never have to have another surgery, right? But we're kind of speculating here as to what could be, but having surgery in one place doesn't necessarily preclude the future option for surgery if medically necessary. But I'm glad they had a good, successful surgery.
Okay, thank you.
Rose, we have one here.
I broke my femur about 2 years ago and already had torn meniscus. And so after my femur, when I would go to physical therapy and I would do exercises, sometimes it impacted my knee, and I get injections for that. When I exercise now, I am in so much pain the next day, and I don't follow through with exercises at home. And is it normal that I am in that much pain after doing a little bit of physical therapy or a little bit of walking?
So again, it's difficult to answer that given, I don't know much clinically about what's going on, but anytime there is sudden changes in your baseline, right? Everybody, if you're experiencing pain, but then you realize there's a sudden change in your baseline, as in, wow, my pain today, I did this motion, and now it went from a, mild to severe overnight, then, at that point, a re-examination is warranted, and possibly even reevaluation with new imaging is warranted, okay? Because again, physical therapy's job is to optimize your body and strengthen your musculoskeletal system. In some cases, when you're doing that, you are changing the way your body distributes pressure, right? Which can cause pain, but that's not, again, it's difficult to determine, but the point is, if you have sudden changes in symptomology, it is important to get reevaluated and possibly update imaging.
We have a question here.
Yeah. Hi, Dr. Bhalla. Are you doing laser?
Yeah, great question. So I'm gonna take that question. I'm gonna kind of use it as a springboard. Okay. So there's a lot of marketing kind of stuff out there. So if you go like if you're Googling, you're gonna get a whole bunch of things that sound wonderful, like laser, and then you see somebody running on a beach with a Band-Aid on their back, and it's just, it's like, how do I sign up, yesterday, and that's marketing, unfortunately, and so sometimes it's unscrupulous. So what I would say is, we want to learn more about what the problem is, and then really use our body of evidence, like, for example, what we've learned in medical school in our training, and the best available evidence around the world, to try to figure out an evidence-based way to treat whatever that problem is. But you'll hear things like that sound amazing, like no needle epidural, which, have you heard that one? Yeah, or like or like a laser or something like that. And then a lot of it is kind of is truly is gimmicky, So it's important to be careful about Dr. Google. Trust me, I want nothing more, and I know Dr. Hanna feels the same way. We want nothing more than our patients to be really well informed about the decisions. We want you to be completely enlisted there, do all your research and stuff like that. But it's hard, and it's a challenge, and I respect that it's a challenge to get good information, get good sources for that information. So we have, and I know Dr. Hanna keeps it at his office, we keep it at our office too, certain websites we might refer you to, like our American Academy of Orthopedic Surgeons or North American Spine Society, where you have really good condensed information. And to try to keep you away from like the ads and stuff like that, because some of that unfortunately is like a clickbait. You know, they try to get you, and so. But we're here to inform and protect and to serve. So we want you to, you know, you have questions, concerns, let us know. There was a question earlier, the lady in the front, it was a follow-up question about the artificial disc or spine replacement. I think that's what they were referring to, I think, an artificial disc replacement. So, yeah, not replacing the whole spine. So that's an option for certain patients where you remove a disc in between two vertebrae and place a mobile spacer there as opposed to fusing it, which is something that can be considered in consultation with your doctor. Yeah.
Okay. I've got a question right here.
What is your opinion on supplements? You know, like glucosamine for arthritis or degeneration and things along those lines?
I'm going to answer that question, but I just want to piggyback off of something Dr. Bhalla said earlier, which is really important. I actually commend all of you for coming tonight because getting actual answers, medical answers in today's world is very difficult, okay? And I mean that because we are inundated with social media, with AI platforms and technologies kind of guiding, you know, people to make decisions that are unfortunately uninformed, okay? So I always will tell you is if you ever have a question, never hesitate to ask, okay? Now, to answer your question, can you just go ahead and repeat it one more time?
What's your opinion on supplements for
Okay.
arthritis, like a glucosamine or
Right.
turmeric or
So supplements, I don't know if, so I'll put this in the nicest way possible. So as long as there's evidence, right, I am for it, right? Glucosamine has some evidence. I'm not fully convinced on it, but you always have to weigh out the benefits and the risks. So I have a close friend of mine who is a hepatologist, a liver doctor, and he actually tells me one of the most common things he sees in clinic is what? Is liver problems due to people taking these ridiculous amounts of supplements to the point where he has actually had to submit to companies throughout America saying, hey, your product, my patient is taking, and this is what's going on. They never had it before. So you have to be cautious. I'm not trying to scare you, but again, a lot of people are, they say this out there all the time, and I challenge this, and I say this in the most loving way to my wife, because my wife loves supplements, but if she sees this, she's probably going to be like, you're not welcome back into the house tonight, but is a lot of people will come tell me like, oh, Dr. Hanna, you're just saying supplements aren't good because you're a doctor and that's your business is to, you know, make money off of patients. And that's not true at all. In fact, people are going to see me whether you have problems or not because there's that many people who need help, correct? But the supplement industry, right, and I don't want to speak poorly of it, there's certain supplements that can be helpful, but if you look at the supplement industry, the financial gains of the supplement industry far exceeds that of what we see in other aspects of medicine because the supplement industry is not also regulated in certain aspects. So to go back to your question is, glucosamine specifically, there is some good data, but to me it's not one of the first things I recommend because I don't think the data is fully there yet.
After I researched it, it said if you're predisposed to glaucoma, don't take glucosamine, which is what the doctor said, yeah, go ahead and take this. But I looked it up when I got home, and I'm thinking, okay, well, which way do you go? You know,
Right.
I am predisposed to glaucoma, so.
Right. There's a lot of, you know, there's so many supplements out there. There's a new supplement that comes out once a week at this point, and people are like, oh, goji berries one week, and then the next week it's, you know, it's just unlimited information, and that's why I was saying earlier, I really, really commend you guys because it's tough. In this world we live in, there's so much information coming from people who truly, unfortunately, do not have the education to answer them appropriately.
Yeah. We had a question up here, I believe.
Oh, yeah, hi. Well, first of all, I wanted to thank you two for coming and spending your time here to educate the community. I think that is wonderful. And I wanted to piggyback a little bit, not with so much with supplements, but your prescription regimen for like muscle spasm, like cervical muscle spasm, like I heard anti-inflammatory, and I don't need to tell what one, but like frequency, dosage, that kind of thing.
So specifically for muscle spasms?
Yes.
I'll answer that. So muscle spasms, obviously, the first thing is, I always ask the patient, how's your water intake, right? How's your diet? The basics of just good health. A lot of patients will tell me, actually, I don't drink much water. I tell them, well, let's start off with just increasing your water intake. Some patients, that'll help. But when it comes to dosage of muscle spasms, there's few true antispasmodic medications. Anti-inflammatories are not antispasmodic, they're just anti-inflammatories. Now, the antispasmodic medications, you have medications like baclofen, you have medications like Robaxin or methocarbamol, as you hear it, Scalaxin. Some people say that Flexeril is a antispasmodic, but that's debated. But the point is, those medications can be of help to relax the muscle. The next question is, and I always love asking this, as you could see, is what is causing the muscle spasm, right? What is causing it? Is it just poor diet? Your electrolytes are off? Is it just poor posturing, poor ergonomics? So kind of understanding what's causing it is also helpful. But the medications for antispasmodic is usually baclofen, Flexeril, which is cyclobenzaprine, and then you have Robaxin and Scalaxin. There's a few other ones that are much stronger, like the diazepine family, but the benzodiazepine family, but those are really reserved if you've really failed everything. But does that answer your question, or you want to know the exact milligrams? Oh. Did you try other? Okay, so did you try other medications? Because just because one doesn't work. Okay, yeah. So just because one antispasmodic doesn't work doesn't mean the other ones won't work. So that's what I do when I evaluate you, is I'll discuss kind of what you've tried and what you haven't tried, and we'll go through the risks and benefits of each one and see what we can switch you to.
We have a question here.
I was just wondering your opinion on stem cell therapy.
You know, honestly speaking, the stem cell therapy, it's in the same bucket as the laser. And I say that to the community, really, like, because I care. You know, so when and not because I want to operate. It's and I know Dr. Hanna feels the same way. When you'll see there's so much advertisement for stem cells, and I think it's a lot of people playing fast and loose, and honestly, I feel like preying on patients who are vulnerable, looking for something because other things haven't worked. And just because other things haven't worked, it doesn't mean you have to try the next thing if it's not evidence-based and stuff like that. So my one-liner I tell patients in my clinic office is, if you hear stem cells, guard your wallet, and that's it.
You mentioned evidence-based. And you also talked about people being spend a lot of time on the internet. We're doing our own research. What, in your opinion, is evidence-based research and to support some of the things that we are reading online?
Yeah, that's a great question. And so when we say evidence-based research is, the truth is, we don't know very much about a lot of things, of course. We acknowledge, like, what we don't know is that's the biggest bucket, right? But there is something called going through the scientific process, right? Where you have a theory and you need to prove that theory. And so in order to prove the theory, you're asking a question and you're doing kind of a well set up experiment that goes through, appropriate kind of rigor in the way it's established, the way it's conducted, the way data is extracted from it. Then that's compiled, and then it's submitted to, peer review committees, so people that are experts in determining whether something meets good evidentiary support. And so when we say evidence-based, we're talking about something that's gone through a process that's really been scrutinized at a high level to see whether it's effective or not. And that's something that when Dr. Hanna would be taught, we would be sitting in medical school class being taught it because it's gone through that rigor, as opposed to someone saying, hey, let's try a laser on you or something like that. Like, it sounds good, but it hasn't been through that process. So we are really coming from a place of humility, where we say, hey, we don't want to prescribe something to you unless we know it has been through the highest level of rigor, so evidence-based backing, because then we feel comfortable prescribing that to you, prescribing it to our family, and actually conducting that treatment ourselves.
Thank you. Someone also asked about the role of a neurosurgeon, and I know we don't have a neurosurgeon here with us this evening, but rightfully so, they deal a lot with both neck and spine pain as well. Would you guys mind speaking about their role? Dr. Hanna, I know you work with many of them as well, and just give us a little bit of a background and where their role is.
Yeah,
Thank you.
We tend to be a little more fun on the ortho side. No, I was kidding. Yeah, but you know, the truth is, honestly, I get asked this question all the time. And sometimes patients are shy to ask me because they know I'm an orthopedic surgeon, and they're like, well, should I be seeing someone else? And you know, I always say you should see whoever you like to see. But I think when it comes to spine, there are neurosurgeons that are exceptional spine surgeons. There are neurosurgeons that maybe not the best spine surgeons. There are orthopedic spine surgeons that are exceptional, and that there are orthopedic spine surgeons that maybe not the best. You know, and so it really comes down to the individual. So there are some centers that, like hospitals, for example, that are really, neurosurgeon heavy. In that area, they tend to be the strongest. And there's some hospitals where it's ortho spine, so it's kind of split. But to give you a little bit more granularity, orthopedic spine means you do a 5-year orthopedic residency, then a 1-year spine fellowship. Neurosurgeons typically have their spine training enfolded within their 7-year residency. Sometimes they go through a fellowship as well. But I think you should seek multiple opinions always, and it's a good question.
Dr. Hanna, knowing that you work with...
Yeah, I agree fully with everything Dr. Bhalla said. I think it's important as patients to know kind of the credentials of who you're seeing, right? So I think someone who is, if you want to get spine surgery, you should see someone who has a fellowship training in spine surgery. Now, just like if you want to see a pain management doctor, you should see someone who's fellowship trained in pain management. That's where they receive their training, so that's their focus. Now, how you get there's so many different avenues, but fellowship kind of provides that anchor in honing in and focusing on that subspecialty. So agree with everything Dr. Bhalla said. In each specialty, you'll find always people who are subspecialists and they're really focused on one thing, and people who are more general. So just good to be informed.
Okay. We have a question here, Rose.
If you're experiencing pain both in the neck and in the lower back, and if you were to, have an appointment with one of you doctors, is that something that would be one visit or multiple visits that you can, address the issues?
So usually I try to be as respectful as I can, obviously, to like all the patients that come see me, but also to the patients who are waiting for me, right? So usually, at your first visit, the evaluation, depending on your symptoms, I'll usually I'll ask you first, what is your worst pain and where? And the reason being is because the way your what we call action potentials, which are the signals in your brain, the way they fire, right, your brain perceives the most painful thing as one. So let me give you an example. If you're walking through a jungle and you get a bee sting in one arm and you get a gunshot wound in the other arm, are you going to feel the bee sting? You're not going to feel the bee sting, right? So I'll always ask you first is, what is your worst pain? And sometimes I'll even hand you a pen and tell you, if I could give you this magic pen, where would you point it to relieve you forever, right? And then we kind of chip away at your pain. It's like, okay, well, let's focus on your neck. Let's take care of that. Then let's move to the next body part. But the way pain works is very unique because it occupies the nuclei or the center in your brain, the cells. Literally, it could fire so fast that that's all you perceive. So when we take care of one, then the next time you're going to be like, now I feel the bee sting. The bee sting hurts a lot. We take care of the bee sting, and the next thing is you're like, oh, my sock is too tight on my leg. So we kind of go down the list. Does that make sense? Okay.
All right, everyone, we want to be respectful of your time. It is almost 7 o'clock. We have spent 90 wonderful minutes together. I know we started a little late. Thank you. I didn't realize that. Please.
Oh, thank you. Thank you. A couple of questions. if there's an extrusion or impingement in the disc, can this is a weird question, but you know, Dr. Bhalla, you know my husband, okay, I'm talking for him. Can this create episodes of severe pain and nausea? Because he's in the emergency room right now, and this is the second time this month, so we just don't know what to do. And then I have another question for Dr. Hanna after that.
Sure. Well, yeah, I'm sorry to hear that your husband's in the ER.
I have another question after that.
Yeah, the symptoms of nausea are likely not coming from a disc. Usually, that wouldn't be the way nerve pain would manifest.
Okay.
That's the answer to that question. Do you want me, and then I'll have Dr. Hanna, you had a question?
The other question is EMG, what does it mean? And is it just it's just a nerve study, right? It's a nerve conduction study, you said, but it's just a nerve study, right?
So EMG stands for electromyography,
Okay.
and that is specific to the muscle testing portion of the needle. So it's when we take the needle and we actually put it into the muscle and we see how the muscle is firing. Nerve conduction study is conducted at the same time when we take the probe and we actually shock you and we see the velocities of the nerve, and we get to compare those velocities and see if there's any drop off or slowdown in the velocities to see if there's any type of entrapment.
So those are two different things. Nerve
Correct, but usually
conduction,
done at the same
nerve
time.
Oh, they're
Yes.
done at the same time.
Yes.
And is stem wave wacky too? I mean,
Stem wave.
yeah, stem wave. Does it go along with laser and?
I'm not
Doctor?
familiar. I'm not familiar with stem wave personally. I apologize. Yeah.
All right. Dr. Bhalla and Dr. Hanna, thank you very much for being here this evening. And thank all of you. I know we didn't answer all the questions, especially some of those that are online. Some of them I think we can probably address in the chat with you after, as it pertain to programs and whatnot. But thank you. And I think, as both of them said, there's a lot of information, but really it's your effort, your time being here to learn more and to be well versed on your health that makes all the difference. So thank you very much. Appreciate it.